esophageal stenting, and he's going to give us introductions and overview of endoscopic management of refractory benign esophageal stricture. What is new in 2025? Dr. Dua, please.
Thank you, chairpersons. Good afternoon, and thank you, Abed, and the organizing committee for giving me this honor and privilege to speak here, and congratulations on your 8th endoscopy conference. I hope you have many, many, many more. I think I may be the only one talking on the esophagus, at least as far as today is concerned, and will be touching base on a very sort of common issue that we face, not necessarily as advanced gastroenterologists doing advanced procedures, but even general GI people and even internists do come across these patients who have these benign esophageal strictures, and this is a problem that we are still trying to fix. These are some of my disclosures, and none of these will be discussed in this lecture, except for a brief mention on regrowing the human esophagus. Now, let me start off by this real case. Nothing can be brought, with emphasis to the audience than discussing really a case what happened. This is a 66-year-old man who had vague abdominal pain, got a CT scan. There was a 2-centimeter cyst in the pancreas, and at an outside hospital, he underwent an endoscopic ultrasound examination, and at that time, they perforated the mid to lower esophagus that they closed with clips. 6 weeks later, this is what happened. There is a stricture in the mid to lower third of the esophagus, and this patient underwent 11 dilations up to a maximum of 12 millimeters. These dilations were done kind of around about 2, maybe 3 weeks intervals. Some of them, they injected steroids. He kept re-stenosing and was referred to us at the tertiary care center for additional interventions like placing a stent or electrocautery incision. So, what exactly is a refractory benign esophageal stricture? It has to be a fibrotic stricturing of the wall, not extrinsic compression, and one cannot achieve a diameter of 14 millimeters or more despite 5 dilations done at 2-week intervals. Or if we do reach a diameter of 14 millimeters, we can't maintain it, and the patient requires 1 dilation every month. This is the definition of refractory benign esophageal strictures. I have certain issues with this definition. Why 14 millimeters? Why 2 weeks? Where did all this come from? And that will dictate how we treat these patients. Now, these refractory benign esophageal strictures are generally complex, long, more than 2 centimeter, tortuous, multifocal. A regular 9 millimeter scope can't go through it. They are generally from corrosive radiation, surgical injuries, mucosal resections, dissections, eosinophilic esophagitis, pill injuries, and in this particular case, it was from trauma. So, here is the issue. Why 14 millimeters? This is physiological studies where they found that if the compliance or distensibility of the esophagus can be more than 14 millimeters, normally the esophageal lumen is collapsed. But when we eat, it distends. If it cannot distend more than 14 millimeters, you develop dysphagia in adults. So this 14 millimeter cutoff came up, that the distensibility of the esophagus, if it is compromised and cannot go beyond 14, then you start developing dysphagia that can be from, grade 1 to grade 4, depending on how tight the lumen is. Now, here is a patient of mine who has a head and neck cancer, and this is the neohypopharynx from radiation. He is cured, 45 years old. Because of this narrowing from radiation, he's on a G-tube feeding, and being in the middle age, he's like in the 40s, and he wants to at least have something by mouth for quality. His nutrition is being maintained, by his G tube. So calorie is not an issue. But imagine at this age, you can't have a cup of coffee or tea or something. So we went and dilated this patient with a balloon and took him up to 8 millimeters. Now, if you look at the area of the circumference that goes by pi r square, from 3 square millimeters, he came up to 50 square millimeters by just going to a diameter of 8. So this is a 16-fold increase, and he can drink liquids and maybe mashed potatoes, soft consistency. For him, this was a remarkable change in the quality of his life. And if I try to bring this guy to 14 millimeters, I'll perforate. So do not go by 14 millimeters. Go by what is your goal to dilate these patients should be dictated by what the patient wants. I would not want to dilate a 95-year-old lady to 18 millimeters and perforate her when all that she wants to eat is a soft diet. So keep that in mind. Now, the other thing is that this particular patient that was sent to us, because it was a mid to lower esophageal stricture, the doctors were treating him with omeprazole, purple pill, that's what this is called. Now, why do we give PPI empty stomach? Because they should start working to block the proton pump before the food touches the stomach. This guy was taking his medication empty stomach, but do you think it ever reached the stomach? It was probably sitting here. So don't forget that many times we treat these peptic strictures with medications that may never reach the stomach. It takes some time to get there. And although there are certain medications like tetracycline, Bactrim, etc., that can cause pill injuries, but any medication that dissolves at the area of the stricture can cause superimposed pill injury. So frequently peptic strictures are called refractory because there are other things going on. Otherwise, they should not be refractory because there are very good medications to treat it. So we looked into all of this in this patient, and let's assume we have 100 such patients. And these are refractory benign esophageal strictures. I'm just trying to make it into simple statistics. So with that, what was happening in this case when he was sent to us, dilation every 2 weeks, 2 steps forward, they come back, 2 steps back. You're going in circles. So why 2 weeks? And then this patient was referred to us. If dilating every 2 weeks makes him go in a circle, then the question becomes, why not dilate him every week? Where did this thing came about dilating only 2 weeks and then you come and put a stent in? So basically what we published in a fair number of patients is that dilation is still the first line of approach in patients who have failed dilation as per the definition of refractory benign esophageal strictures. Dilate them every week. At each dilation, see how much the patient has regressed. And then if the patient starts regressing less and less, increase the interval between dilation until you reach a point where the patient just calls you when he needs dilation. The second thing that I have noticed is that when you have multifocal strictures, like in this particular situation, there's a stricture that is below 14 millimeters, it is 11, and then there is this tight area of 4 millimeters. With an endoscope, which will pass through this area, you will see a tight area, you will balloon dilate it, but you will forget that there's another area that is below 14. So I've found that wherever you suspect multifocal strictures, use a bougie. Bougie will dilate from top to bottom. And any areas that your scope may have missed that are non-compliant, it will dilate the whole esophagus. Now, with this approach, what we found is that those who were sent to us with failed dilation for stenting, we just dilated them every week, and we found that 33% of them started responding. It took many dilations, but eventually they started responding. Our patient, unfortunately, fell in the red zone. He didn't fall in this 33. Now what do we do? Now we get into other interventions. And here is where I'm not describing any of these studies that came out. Esophageal stents that can dilate, remold strictures, you pull them out. I've noticed that when you pull them out, the stricture can come back with a vengeance. It closes up again. But anyway, multiple studies, including biodegradable stents and so on, have found that the success rate of placing esophageal stents and then pulling them out in about 4 to 8 weeks is around about 80% at the upper limit, and then when the strictures are more higher up in the cervical esophagus, it can be as low as 46%. If there is a short stricture, you can cut it with a needle knife and use electrocautery. Now, one thing that our approach changed, if you cut the edge of a paper and you stretch the paper, it tears. So if you needle knife, I would like to stretch that area immediately after needle knifing, but then I can cause a perforation. So one of the techniques that we use over here is that I needle knife to the maximum, maybe there's a micro perf, and now to tear it more, right away, I put in a fully covered metal stent. So it'll tear that area more, and it'll also seal a micro perf in the process of stretching. So these combination things, they are not like much data in that available to show that putting a stent after needle knifing is going to be better, but that's some of the things that we are like doing in our practice. And as you see over here, for time's sake, a lot of work has been done on electrocautery incision. If the stricture is short, 100% response rate in one session. If the stricture is long, you may require up to almost 3 sessions to open it up. But in these studies, no stents were put in immediately after. For example, if you put a stent in over here, it'll tear it open like this. And even if there's a micro perf, it'll seal it open. Now here is where we changed course, and these are some of our publications. 2 of them are coming out in press. When other interventions are employed, and when you pull the stent out, or you needle knife, the area looks open. Why do we fail? Why do they develop restrictures? We were trying to figure that out. So what we do in our practice is after this, any intervention is performed, we go back to weekly dilations. Remember, our guy failed weekly dilations protocol, 33% respond, our guy failed. After other interventions, we immediately go back so that we don't lose out on the gains we made after stretching the stricture. And then with this approach, what was found that from 33%, when we went back to weekly dilations after other interventions, we reached almost 60% success rate. Now, what is interesting is that these patients were sent to us from outside hospitals as failed dilations. But what if you can predict at index endoscopy that this stricture is going to be refractory? First time you go in, you can make a judgment that this stricture is going to be refractory, and you start using this protocol right away. And this is the study by Bell coming out in GIE that I was asked to write an editorial on. They could predict at index endoscopy that the stricture is going to be refractory. And in those cases, if we use this protocol upfront, our success rate reaches 83%. So mind you, these are patients who are potentially failed dilations type of patients. Now, this is the region where we still have a problem, roughly around about 15% of these patients. We need to figure out what's happening. So in our patient, we put a stent in, we took the stent out, the stricture remolded like this. He still required 1 dilation every 10 to 12 weeks. Initially, he accepted 4 to 5 dilations per year, then got frustrated, refused surgery. What next? So we have now started this in a very aggressive manner. We have a clinic called the self-dilation clinic. This is that patient. He has given me permission to record him. We don't have sound over here, but actually in my presentation there is sound. We make the patient sit in front of a fluoroscopy monitor while he is placing the self-dilation down, he is watching the screen as a biofeedback. We encourage him not to hold his breath, continue breathing, and also swallow. And this is our speech pathologist over here, Jennifer, encouraging the patient to take the dilator down, and then we switch the fluoro off and ask him to do that again. It is just 15 minutes of training. That's it. And now he's doing it without fluoro. And 3 months later, I got him back to record him again, and you can see he's been dilating himself. He knows to take it, and look at the amount of weight he put on. So self-dilation is an underutilized system. Now, even with head and neck cancer, where the stricture is very high, and we have people with even tracheostomy, those also do very well with self-dilation. For example, this is one of my patients who has got a tracheostomy. Laryngectomy was done on this patient, head and neck cancer, very tight stricture in the hypopharynx. And he's got an even larger diameter that he's dilating himself every day, twice daily. So this is another, situation where I try to introduce self-dilation in these patients sooner than later, not as the last alternative. We, as I said, have a now self-dilation clinic. Now, problem with self-dilation becomes this: when you have a diverticulum or you have a ledge, they put the dilator down and you see how it curls. So in these patients, we came up with an idea which, as I said, is coming out in press, how to even deal with these kind of situations. So what we do in these patients is that we can needle knife this ledge, or we don't have to, put in a stent, take the stent out. This is the same patient, by the way, and look at this area, how it opened up. Now you made it straight. In the morning when we pull the stent out, the same afternoon we made this patient do self-dilation. And what we did is that we bought the patient a self-dilator which is smooth but blunt. Because if you take the traditional bougies, the tip of this can hit the opposite wall of the stomach and the patient will find resistance. But if you take this self-dilator, it can go down across this area. Now, self-dilation is not new. One case in 61, another 3 cases in 1961, 13 patients with a total of 4,600 self-home dilations in 1984, and a relatively recent study, up to 60 French. You know what is unique in all these studies? Success rate very high and no perforation. Why? You can't perforate yourself. I can perforate if you're under propofol. But you dilate and you have that discomfort, you'll stop. And with this approach, in that particular case of mine that I showed you, we reached 100%. Now, last few slides, and I'll wrap it up because I think I may be running over our time. Now, what happens when we dilate these patients, or we put a stent and we pull it out, or we use electrocautery incision? These are the strictures. You cause epithelial damage, a lot of mucosal injury, and the healing process takes you back to the stricture. And when you have this, you're basically going in circles. You're dilating, you're causing mucosal damage, and this heals with a stricture. Currently, our focus is mostly on this area, from dilations to cauteries to stenting, but we are forgetting this part of the equation. Why this is important? If you look at mucosal injury, fibrosis develops in 2 weeks, and epithelial cells from the sides come, and the re-epithelialization takes up to 5 weeks. By that time, the lumen has already distorted. So in this particular case, there is nice healing. And you biopsy this, it will be squamous epithelium, but the lumen has already gone stenosed. That is because fibrosis sets in 2 weeks and epithelium takes 5 weeks. One way to overcome this is to inject steroids and delay fibrosis, and the results have been mixed. But how about hastening epithelialization? What if I can make that area epithelize in 24 hours? Or put a new epithelium immediately after I dilate the patient? Will it make a difference? A lot of regenerative medicine work is going on in this area. Autologous pluripotent cells are being injected at the site. They take the adipose tissue, suspend it into buffer or buccal keratinocytes after dilation, inject it, or they can grow the epithelial cells into cell sheets and apply it. This not only is for strictures, but also for circumferential ESDs. This is self-assembly peptides. We talked about that this morning, that we can use, and these self-assembly peptides, they come in a liquid form. Purastat, you heard about the Purastat this morning. People have been using it for bleeding, but you can actually spray it after mucosal resection. The peptides are randomly, nanoparticles are randomly present in the fluid. When they touch tissue, they align and they form a carpet. And that's how you'll find that if you dilate and spray it with Purastat, will it make a difference? Or we can grow the esophagus. So there are a lot of these regenerative medicines coming up. So at the end, in summary, what is new? Set the goals. When you have these patients, ask what they want. A soft diet, they want to eat regular diet, and tailor whether you want to achieve 14 millimeters and go higher, or what is appropriate for that patient. So it's not always essential that you need to go at this level and put the patient at risk of perforation. Preferably start off with weekly dilations and then adjust as per response, and go back to weekly dilations with larger dilators after you apply other interventions. So if somebody comes with 2 millimeters diameter, to take that patient to 14 millimeters, dilating every week will take you about 5-6 weeks. But what if you put an 18 millimeter stent that will stretch it, and in about 1 week, you'll go from 2 millimeters to 18 millimeters. And then when you pull the stent out, now you have an 18 millimeter lumen. Start dilation every week. But even better, start dilation every day, maybe 2 times a day, and that is where self-dilation comes in. So a lot of my patients, when I have them with a lumen of 8-9 millimeters, I put in a stent, maybe gently dilate it a little bit so that when the stent expands, it doesn't hurt. The stricture is now stretched to 18 millimeters, and the patient is immediately told to do self-dilation. And instead of dilating every week, he's dilating every day, he or she. So that is where consider self-dilation before recommending surgery, but as an additional thought, actually use self-dilation sooner than using it at the end of the game. Start using stent, at least in some cases, to dilate from a small diameter to a bigger diameter rather than 18 or 11 dilations. Consider dilating slowly with a stent and go to self-dilation. And then last but not the least, we have now tissue matrices in our surgeons, whenever they do gastric pull-up and they anastomose the stomach conduit to the remnant esophagus, they cover it with a placental membrane that is available in the market nowadays. And that has also shown to be, reducing the leaks that can happen with anastomosis. What about using it immediately after dilation? Thank you.